Hello students, welcome to EPG Pathshala. I am Satwanti Kapoor from Department of Anthropology, University of Delhi. So today's topic of our discussion would be the module Chronic Disease and Body Composition from the paper Applied Anthropology. The learning outcome of this module are to understand the concept of body composition, different level of human body composition and its assessment. Chronic diseases and risk factors associated with body composition. The association of body composition with chronic diseases. First of all, I'll give you a brief introduction on body composition. The term body composition can be defined as the makeup of the body in terms of absolute and relative amount of skeletal mass, muscle mass, adipose tissue, internal organs and other tissues, as given by Boggin 1999. Measuring body composition is significant for assessing a person's health status, and it can be helpful for establishing optimal weight for health and physical performance. Fat-free mass, abbreviated as FM, and fat mass, FM, have many medical implications and are helpful tools to evaluate the nutritional status. However, other components of body composition also influence health outcomes, and there are growing evidences which link body composition with health risks together. Excess body weight may lead to certain level of obesity and increased risk of variety of chronic diseases, while deficiency in energy stores due to inadequate body fat is associated with morbidity and mortality. James et al. 1988. Ideal body composition is one of the components of fitness, and it is being used increasingly in the assessment of growth and nutritional status, fitness, work capacity, diseases and its treatment. Norgan 1995. Please have a look at this figure which shows level of body composition, a descriptive view. There are considerable changes in the chemical composition of the human body throughout life cycle. The chemical components of body, which represents the absolute and relative proportion of water, mineral, protein and lipids, are influenced by growth, maturation and aging. The 5-level model in body composition, which is known as the central model, considers the body mass as a sum total of all the components at each of the 5 levels, namely atomic, that is carbon, oxygen and hydrogen; molecular, that is water, lipid, protein; cellular, extracellular fluid; tissue organ, adipose tissue, bones, skeletal muscles, visceral organs; and whole body, head, trunk, appendages. Wang et al. 1992. At the atomic level, the body mass consists of 4 elements: oxygen, carbon, hydrogen and nitrogen. Other elements such as potassium, calcium, sodium, chlorine and magnesium are also accounted. Now, molecular compartments consist of water, lipid, protein, glycogen, bone minerals and soft tissues, etc. Thus, the body weight is viewed as body weight equals water plus protein plus mineral plus fat. Various other models can be created from molecular level, ranging from the 2-compartment model to 6-compartment model. Now let us discuss about the 2-compartment model and 3-compartment models. The 2-compartment model consists of fat mass and fat-free mass. Fat-free mass refers to the body weight minus the ether extractable fats, while the fat mass include the storage and essential lipids. Fat and lipids are often used interchangeably, but in body composition research, fat refers to the specific family of lipids, that is triglycerides, whereas lipid refers to ether or chloroform extractable lipids such as triglycerides, phospholipids, etc. The cellular level of body composition consists of extracellular solid, extracellular fluid and cells. The cell can be additionally partitioned into 2 components: body cell mass, BCM, the metabolically active component, and fat. The tissue organ level, the body composition consists of adipose tissue, organs, skeletal muscles, visceral organs and bones. Adipose tissue consists of adipocytes with collagenous elastic fibers, fibroblasts, and blood vessels. Single solid organs such as brain, liver, spleen, and heart, etc., are also other organ level components. The whole body level of body composition consists of regional, like appendages, trunk, and head, which are usually described by anthropometric measures such as length, circumferences, and skin folds. Body mass index and skin fold thickness are considered as the most common anthropometric indicators of body composition. The 5-level model clearly manifests the relationship between the major body components and the basic structure of human body. There are various models for partitioning the body mass into meaningful compartments. The most commonly used method for assessing body composition are two-compartment model, which includes fat and fat-free mass, expressed as body weight, which equals fat-free mass plus fat mass, and three-compartment model consisting of body fat mass, FM, partitions fat-free mass into fat-free dry mass, FFDM, and total body water, which is TBW, expressed as body water, equals total body water plus FFDM plus FM. The models which include 3 or more components are referred to as multi-component models. Now, body composition in general is defined as the relative proportion of fat-free mass and fat mass. Body fat includes essential and energy stores or storage body fat. Essential body fats are found in the nerve tissues, cell membrane, bone marrow, and organs. Energy stores or storage fat represents the energy stores which accumulates and decreases with respect to nutritional and physiological conditions. Poskett 1995. Total body fats percentage for young men is estimated to be between 12% to 15%, and for young women it is between 25% to 28%. Now let us understand the methods for assessing body composition. There are two principal methods for assessing body composition, namely direct measurement by chemical analysis of the animal body or human cadaver, and indirect estimation by hydrostatic weighing, simple anthropometric measurements, and other clinical and laboratory procedures. The common methods include anthropometry, especially skin fold thickness, bioelectrical impedance or total body electrical conductivity, computed tomography, X-rays, air plethysmography, ultrasound, water displacement method, computed axial tomography, CAT, magnetic resonance imaging, MRI, neutron activation analysis, isotope dilution, etc. Now, chronic diseases. Chronic diseases refers to a medical condition or disease which persists for a long time. It is of multifactorial etiology which has their origin at a young age and takes decades to become fully established. Chronic non-infectious diseases include type 2 diabetes, heart disease, stroke, hypertension, dental disease, cancer, chronic respiratory diseases, and osteoporosis. Now, chronic diseases, also known as non-communicable diseases or NCDs, are nowadays major global burden in public health. By the year 2020, the burden of NCDs is expected to increase to 57%, and it has been projected that in developing countries, 71% of deaths due to ischemic heart disease, IHD, 70% of deaths due to diabetes, and 75% of deaths due to stroke will occur. What are the risk factors for chronic diseases? The burden of chronic disease or non-communicable disease, NCDs, are greatly influenced by societal factors such as socioeconomic status, education level, employment, and environmental factors that influence behavior and lifestyle, leading to the development of chronic diseases. With the economic development, rapid urbanization, food security, and increased health care services in developing countries, there has been decline in undernutrition related diseases. However, these factors on the other hand have exacerbated the development of chronic diseases due to unhealthy diets, sedentary lifestyle, and lack of physical activity. Chronic diseases are now a major global burden in public health. The role of environment as determinant of chronic disease is well established. Environmental factors in association with the social factors such as socioeconomic status, form a chain of events that influence the behavior, leading to the development of biological risk factors that cause the chronic diseases. Modifiable risk factors such as unhealthy diet, physical inactivity and tobacco use triggers the development of chronic diseases. Altogether, these may serve as an intermediate risk factors of raised blood pressure, abnormal blood lipids, raised glucose level, overweight and obesity. Harmful alcohol use is also a major contributing factor. Chronic diseases are a complicated disease entity and are interconnected in various circles with other diseases in the sense that they become risk factors themselves. For example, there is strong association of overweight and obesity with hyperlipidemia and insulin resistance. All these risk factors contribute to the development of diabetes and cardiovascular disease. Thus, these results in clustering of risk factors, the so-called metabolic syndrome, which includes dyslipidemia, hyperglycemia and hypertension mediated by insulin resistance, and the end can result in the development of type 2 diabetes. Now, association of human body composition with chronic diseases. Body composition has a wide range of health consequences and influence susceptibility to disease. Distribution of total and relative amount of fat represents an independent risk factors for certain diseases. It is important to understand how changes in body composition relate specifically to risk for chronic disease, morbidity and mortality. There is a strong association of androidal distribution of fat on the upper trunk of the body with hypertension, non-insulin dependent diabetes and gallbladder disease, and a more typical of man, diabetes and gallbladder disease. And this type of distribution is more typical of man. The gynoid distribution, that is tendency to accumulate fat on the hips, thigh and arms, are more common in women. The most common disorder related to abnormal body composition is obesity, defined by excessive accumulation of body fat resulting in adverse effect on health. This can lead to abnormalities in carbohydrate metabolism, high lipid, high blood pressure and a major risk factor for development of non-insulin dependent diabetes. Development of non-insulin dependent diabetes. However, there are several diseases associated with abnormal distribution of body water across the intracellular and extracellular spaces due to inadequate storage of fat and proteins in the body. Body composition and metabolic diseases. One of the major interests in the body composition research is the health implications of fat and has been declared as an epidemic in developed countries, WHO FAO 2003. In both developing and developed countries, due to nutritional transition, unhealthy dietary and lifestyle pattern, chronic or non-communicable diseases have become principal global cause of morbidity and mortality. India at present faces a combination of chronic diseases and communicable diseases where the burden of chronic disease exceeds that of communicable diseases. Now, metabolic diseases such as type 2 diabetes, hypertension, hyperthyroidism and obesity are strongly associated with the weight loss or gain or alteration of body composition by directly affecting the metabolism of carbohydrate, fat, lipid and proteins. Major health implications or disorders due to abnormal body composition are discussed as follows. Obesity and body composition. Obesity is an excess accumulation of body fat resulting in adverse effect on health associated with chronic disease. Obesity is defined in epidemiological research as a BMI, which is body mass index of 30 kg per meter square, though obesity can be determined by many other methods. Calculation of BMI defined as weight in kg divided by height in meter squares is widely used to classify underweight, overweight, normal weight and or obesity. In adults, however, a given BMI may not correspond to a specific population as body fat distribution varies according to body build and proportions. There is a higher risk of developing chronic diseases with individuals having excess abdominal fat and have tendency to deposit excess subcutaneous fat and visceral fat in the abdominal region as compared to individuals with excess fat in the lower body parts. The fundamental cause of obesity is excessive consumption of high calorie food with less physical activity levels, that is, when energy intake is in excess of expenditure. Obesity has multifactorial epidemiology such as genetic, environmental, psychosocial, age, sex and socioeconomic factors. Influence of obesity on body composition. Increased body weight is the most fundamental change in body composition associated with obesity. BMI is an accurate surrogate marker for adiposity with individuals who are obese. Jackson et al. 2002. However, obesity not only involves an increase of body weight but may also affect density of fat-free body and distribution of body water across the intracellular and extracellular spaces. In some individuals who are obese, triglycerides present in the adipose tissue may increase in addition to water. Durenberg et al. 1989. Although there is a high variability among individuals, researchers have noted the level of hydration to be higher in obese men and women, 74.2 to 77% FFB, as compared to leaner individuals, 72 to 74% FFB. Abu et al. 1989. Obesity is also known to affect the metabolism of proteins and minerals. In obese men and women, the relative amount of minerals 7.2 to 8.1% and protein 20 to 21% are higher than the assumed values, which is 6.8% and 19.4%. Fogelholm et al. 1997. Diabetes mellitus and body composition. There are two clinical types of diabetes mellitus, namely type 1 and type 2. Type 1, also known as insulin dependent diabetes mellitus, is characterized by high blood glucose level, hyperglycemia, which is caused by the lack of insulin production due to autoimmune destruction of beta cells of pancreas. Now, type 2 diabetes, often referred to as non-insulin dependent diabetes mellitus, is characterized by insulin resistance, where the body is unable to utilize the glucose derived from the carbohydrates, food or glycogen stores in the tissues. Diagnosis of type 2 diabetes usually occurs on the onset of middle adulthood and is associated with obesity, which leads to elevated blood sugar and itself can lead to insulin resistance. There is increasing reports of children with type 2 diabetes and have become serious health issue in young age. It has been estimated in the adult population that the prevalence of diabetes mellitus will rise from 4% in 1995 to 5.4% in 2015. Obesity is a major risk factor for development of non-insulin dependent diabetes. In the past 2 decades, epidemiological research has been examining the association between adipose tissue and insulin resistance. Abnormal fat distribution and certain patterns of adipose tissues have found to be associated with the so-called metabolic syndrome, commonly referred to as MS, characterized by metabolic syndrome, commonly known as MS. It is characterized by raised blood pressure, insulin resistance, abnormal blood lipid levels, raised fasting glucose level, overweight and obesity. Insulin resistance is a principal mechanism by which obesity is considered to increase risk of type 2 diabetes. Now, measurement of waist circumference also helps in assessing the aspect of fat distribution and also the risk of developing disease like diabetes mellitus. WHO has classified cutoff values of waist circumference according to which a waist circumference of greater than 102 cm in men and 88 cm in women is a risk factor for type 2 diabetes, cardiovascular disease and hypertension. However, these values were received for Asian Indian population as 90 cm in men and 80 cm in women. Measurement of visceral adipose tissue helps in understanding the type 2 diabetes and insulin resistance. Abdominal adiposity and subcutaneous abdominal adiposity were enabled through magnetic resonance imaging or MRI and computed tomography CT. Visceral adipose tissue has been found to be associated with insulin resistance, increased risk for hypertension, glucose intolerance and dyslipidemia. Now let us know how diabetes influences body composition. Earlier, type 1 diabetes was commonly thought to be a catabolic disease, producing loss of protein and fat-free mass. The fat-free mass of individual with type 1 diabetes was normal at the onset of the disease, even though the body weight was 6.5 kg below ideal weight and fat mass was 25% lower than that of the healthy individuals. Rosen-Falach et al. 2002. Researchers have concluded that uncontrolled type 1 diabetes produces a fat rather than a protein catabolic state. Individuals with type 1 diabetes tend to have a less value of total body fat, abdominal fat and percent body fat as compared to healthy controls, and type 2 diabetes patient Gomez et al. 2001. Now, thyroid disease and body composition. Thyroid stimulating hormone TSH generally controls the metabolic function, including metabolism of fat, protein, carbohydrate and minerals. Hyperthyroidism is characterized by increased secretion of thyroid hormone and Graves' disease, which is the most common cause of autoimmune disease, Beers and Barkov 1999. Whereas hypothyroidism is caused due to deficiency of thyroid hormone resulting from autoimmune thyroiditis, that is inflammation of the thyroid gland, and this disease is often associated with a farm goiter. Now, influence of thyroid disease on body composition. Maikawa et al. 1999 studied the body composition of patients with thyroid disease using BIA, which is bioelectric impedance technique, as compared to age and gender matched healthy individuals. It has been found that patients with hyperthyroidism tend to have less body weight, body fat percentage and body cell mass BCM. It was also found that the reduction in BCM was attributed to a loss of muscle mass. Also, loss of significant bone mineral is a consequence of hyperthyroidism. Cohen et al. 1973. However, when the BCM of patients with hypothyroidism when compared with healthy control, it was found to be almost similar, even though these patients were fatter and weighed more than the healthy individuals. Now, body composition and cardiopulmonary diseases. Individuals with coronary artery disease, which is called as CAD commonly, tend to be overweight and obese, while individuals with cardiopulmonary disease such as chronic obstructive pulmonary disease and heart failure often lose weight and lean body tissue because of muscle wasting and depletion of bone minerals. So, body composition assessment is required for monitoring these patients to enable the clinicians to provide adequate nutritional support. Now, coronary artery disease, commonly called as CAD, and body composition. Pathological lesion leading to CAD is called atherosclerosis, defined by accumulation of complex carbohydrates and lipids in the blood vessels. This leads to thickening of the arterial vessels of the body in cerebral, abdominal and peripheral circulation, and thus interferes with the oxygen supply to the heart muscles, myocardiums. Individuals with coronary artery disease tend to be overweight or obese and tend to have more body fat on the upper body part. Patients with this disease have an altered fluid status due to increased total body water and extracellular fluids, Masari et al. 2001. In addition, with the congestive heart failure, plasma volume increases and fluid started to accumulate in the lungs, abdominal organs and peripheral tissues. Now, body composition and chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease or COPD are a condition in which the airflow to the lungs is obstructed. Emphysema, permanent enlargement of air spaces in lungs, and chronic bronchitis, persistent inflammation of the mucous membrane of the bronchi caused by bacterial infection or lung carcinoma are the most common respiratory problems often associated with patients with COPD. Now, individuals with chronic obstructive pulmonary disease or COPD often lose weight and lean body tissue because of muscle wasting. In a study, it was reported that half of the patients with either COPD or severe respiratory insufficiency were underweight, BMI equal to 18.5 kg meter square, but only a few of the patients with overweight, BMI equal to 27 to 32 kg per meter square. Now, COPD patients had moderate to severe bone mineral loss as compared to healthy age-matched controls. England et al. 1998. Cancer and body composition. Body composition not only contributes to the understanding of cancer etiology but also enhances the ability to identify the high-risk population for prevention and early detection. Cancer remains the second leading cause of death in the United States before 1999. The elevated incidence rate of cancer in these populations are associated with a high prevalence of obesity in developed countries. Kale et al. 2003. Obesity and physical inactivity often coexist and together account for 1/4 to 1/3 of worldwide cases of colon, breast, kidney, esophagus and breast cancer. Anonymous 2002a. Reduced muscle mass and increased bone density are also related to increased cancer risk. Now, breast cancer. Several studies have been done to understand the relationship between body composition or body size and cancer. As mentioned earlier, the elevated incidence rate of cancer in Western countries may be linked to the high prevalence of obesity, Stoll 2000. Vanden Brandt and colleagues in 2000 year in the analysis of 7 cohort studies found that for every 4 units kg meter square increment in BMI or body mass index, or for every 10 kg increase in weight, there was approximately a 10% to 11% reduction in breast cancer among premenopausal women, but a 6% to 7% increase in risk for breast cancer among postmenopausal women. This appears that obesity is protective on premenopausal women and appears to be associated with postmenopausal women. Kumar and colleagues 1995. In a case control study, it was observed that women who progressively gain weight from puberty to adulthood, especially in the 3rd decade of life, have a higher risk for developing breast cancer. Now, abdominal fat distribution may also contribute to this disease. Birmingham study after 28 years of follow-up reported that central subcutaneous fat instead of general adiposity was associated with subsequent breast cancer among women aged 30 to 62 years. In a study, it was found that the waist circumference to hip circumference ratio, which is called WHR, was significantly higher in women with cancer as compared to age-matched controls. Visceral obesity is also a significant risk factor for breast cancer in women. Now, insulin resistance and high insulin growth factor IGF levels among obese women are other possible links to breast cancer risk. There are many other inflammatory diseases associated with body composition such as rheumatoid arthritis RA, osteoarthritis, inflammatory bowel disease. Rheumatoid arthritis is an autoimmune disease caused due to destruction of joint cartilage and bone. Loss of fat-free mass is a hallmark of RA. Now, this module can be summarized as follows. Now, body composition has a wide range of health consequences and influences susceptibility to diseases. Distribution of total and relative amount of fat represents an independent risk factors for certain diseases. It is important to understand how changes in body composition relate specifically to risk for chronic disease, morbidity and mortality. Monitoring and assessing body composition not only contributes to the understanding of etiology of chronic diseases, but it also enhances the ability to identify the high risk population for prevention and early detection. Measuring body composition is significant for assessing a person's health status, and it can be helpful for establishing optimum weight for health and physical performance. That's all for this module. Thank you very much.